Hey guys. So I've had a number of people request an update on ARDX. I haven't really had time to do these videos anymore. I just have other things going on. But I figured I would do that very quickly since their PDUFA date is coming up. So again, this is not investment advice. I'm not even putting this in slides. I just made a series of points. A lot of this are going to be things that you know. Some of it is just to describe my thinking, if that's what you're interested in. I don't think there's been much material change in any real way in quite some time. It's really the same thing. There's just distractions for the most part. But so let's start with this. The PDUFA date is 17 October. It's about 7 weeks away from today, which is the 27th of August. And by then we'll know, is Exfosa going to be approved or is it not going to be approved? If it isn't approved, I don't believe that means that ARDX is necessarily done as a company. So Ibsrela is selling, and I think what would happen next is they would take the FDA to court because there would be some lawsuits involved. And I think the reasoning behind the lawsuits would simply be there were endpoints, the endpoints were met, the AdCom was won, the appeal was won. What other thing could they possibly ask for? Or what reasoning could they have to keep this drug off the market? Now, the argument that, if you listen to the AdCom, the argument that was being made, not by the FDA, but we'll say FDA side, was, sorry about that, was that if you look at Exfosa versus, say, phosphate binders, and you look at the efficacy, they have a fairly similar. It's about the same profile. So different. There are a lot of different tests, and I've looked through most of them. I haven't looked at them in a while, I'll be honest with you. But what I saw was that you take Exfosa, and usually I think it was around 2 milligrams. So they were saying hyperphosphatemia is diagnosed anything over 4.5 milligrams phosphorus in the bloodstream as a profile, and then anything above they were diagnosed. You have that condition. And then let's say they were doing tests at 6, they would get it down about 2 milligrams, which was what the binders were doing. So the argument on the course of the FDA was, why would we approve something that's essentially the same degree of efficacy? Which the argument on behalf of the physicians who were on the winning side of the AdCom was, there are a couple of them. So first off, adherence is an issue. Second, this is from a clinical trial. It's not based upon the reality of practice. And then also, how can you? And I think this was one of the best arguments. How can you? You're comparing a dose of 4, 5, 6 pills to 2 pills. So you're comparing. If I take a baseball versus a marble, and I say that the baseball is as effective as the marble, well, they're not the same thing. So it's an apples to oranges was one of the arguments made in the AdCom. So will they get approved? I don't know, but I think that there's still quite a lot that they could do if they weren't approved. And I would put it like this. I hold quite a significant amount of ARDX stock, and I personally, this is not investment advice, but I personally am betting that it's going to get approved. I think it's a high likelihood, over 80% chance is what Cantor just said. So let's move on to that. Recent price fluctuation. It's been jumping between 350 and 4. I stopped swing trading. I'm just holding this. I don't really even care. Recent jump on Friday was 40 cents. At some point, which you could say that's because of Cantor, you could say that's because of the Fed, and they're still talking hawkish, but the tone isn't as hawkish, and it seems like there's a lot of signaling that within 2023 and 2024, maybe there's some additional interest rates, but it's not going to be as aggressive. And then by late 2024, it's probably going to be a pullback in interest rates, which means there'll be more money in the money supply, which means that pricing will start to level out a little more stocks, and you'll see some more stock stuff, which in and of itself, in a macro sense, means the Fed is saying, listen, we won't beat you up if the stock market goes up. That's what they're saying, because that's what they've been doing since last year and really 2022. They've been beating up the stock market, where anytime it goes up, the Fed comes in and says, hey, stop it, because we don't want that much cash out there, because they're trying to curb spending and bring the interest rate, or bring inflation down. So I don't know if Friday's the jump was because of the Fed or if it was because of Cantor or was because of something else. My opinion, my humble opinion, I think that at a certain point, the financial analysts are are signaling to a heavily shorted stock because there's over 27 million shares as of the middle of the month, that hey, you guys might want to get out of here, get out of there because this is going to start to go up, and it's going to go up because it's likely to be approved. They met with ARDX. We have no idea what they said, but I think that they probably saw some very good numbers, and they saw some good numbers, and they think that there's definitely something happening here. Cantor raise, the next point, Cantor raise projection, and I'm down here, to $10 and release their estimates. Okay, so I looked at their estimates and their projections. So the projection is $10 within the next 12 months as a share price, and their projection was it's going to do better than they expected, but their actual numbers showed negligible, and I would say almost a complete dud of a launch of Xphozah over the next 2 years for their estimates, which means I don't buy it. I don't think that that's accurate. And I think that, I don't think those are the numbers they really have. I think that's just what they publish because they can publish that. They said $5 after meeting with ARDX, or what they actually, let me back that up. I don't think that that's what they actually expect, because if I go by those numbers, I wouldn't think that they would move the estimates up. They move the estimates up as a signal to the market, in my opinion. The numbers they release, they're releasing those because they're going to hold that back. They said $5 after meeting with ARDX, so they had one set of estimates that were released, and then very shortly after they upped it. So, this is how the market works. They're the people who get the info and the people who don't. What will sales be? I have no idea what sales will be. I'd be lying to you if I told you I think they're going to do this. I think they're going to do that. Meaning I have no concrete idea. I have what I have estimated based upon what I am investing. I'm not going to share that. I'll say this. I think they're going to do well with Xphozah. What will the price be? I have no concrete idea, but again, I have what I estimate. If you're on StockTwits and you look around, you can see what I use. I haven't been posting it recently, but what I would estimate, I usually just post numbers. So, if they capture 30%, they're going to get this. If they capture 20%, they're going to get this. What we do know, so here's what we know in terms of the market. And that's the next point. Why do I have such a large ARDX holding? So there is a definite unmet need. I'm going to get to this article here shortly, which talks about this, but everyone knows the numbers. There's roughly 2 million patients on dialysis worldwide, 550,000 in the United States, and estimated many, many others who are not receiving treatment because they have not been diagnosed. They're just not getting any kind of care. So they should be on dialysis, but they're not. They're just going to die from kidney disease, from chronic kidney disease. That unmet need within the United States, which is the largest market by far, there's just more money for healthcare in the U.S. So you have 550,000 people on. I'm going to go here. So you have 550,000 people on dialysis. 45% are taking all of their prescribed phosphate binders. Patients on dialysis can have greater than 20 pills per day. And 30 to 50% are having adverse effects from the current binders such that they discontinue their treatment, and those are typically the ones who have the worst outcome, which is what you find up here. So they're prescribed to 80% as a single therapy. Half receive it where they have multiple phosphate binders. So you have 275,000 people in the United States who are getting multiple binders prescribed, and then I won't do the math, but we'll say 375,000. 375,000 have a binder that they have to take. Of those, 70% aren't reaching their actual need, and then you have all these other numbers where if they have any kind of problem, if they can't do it, you can get up to 30%, 30 to 50% have an issue, which can lead to them to discontinue taking their binders. Half of the patients aren't taking all of their prescribed binders in a month. So if you think about that, so let's just look at those numbers. 80%, that's 375,000, get a binder. Okay. And then additional ones get multiple ones, but I don't even care about that. 80% are getting a binder. Of those, half aren't taking them. So this is 375,000. Cut that in half. You're getting 180,000 who aren't taking all of them. 180,000 people today aren't taking out all of them. Out of this group, 70% of those, they aren't reaching the 4.5 milligrams phosphorus level that is necessary to no longer have a diagnosis of hyperphosphatemia. So you have 180,000 who stop taking it, all of which have this diagnosis, and a fair percentage of them are not reaching the levels they need to reach anyways. So I would say if you have that tool in that toolbox from day one, it's just a matter, and this kills people. So high serum phosphate levels have been associated with increased morbidity and mortality in dialysis patients. Boom. Meaning this causes a problem. People die from it. They suffer pain from it. I think the number one thing, if you look at what it is, it's like any metabolic issue. It's like if you have a liver issue, if you have kidneys issue, it's just your life gets bad because when you eat, you get sick. That's what it is. It doesn't clean your blood. Your blood isn't getting cleaned out, and you get sick. It's continuously getting worse. So what's happening is that you have a treatment which is for 375,000 people, where half of them, 180,000 stop taking the pills just because the pills make them sicker than the impact of the food. What are the doctors going to do? Well, the question is, of those 175,000 people, how many of them will get a prescription for Xphozah? I would think a fair number. I mean, I would hope. Now let's look at the math very quickly. At least they would try to see who can be helped by this. So let's say I'm talking about 180. So we'll take 550,000 times 0.8. Jeez, lost it. Yeah, I'm not doing much editing here, guys. I have other things. So that's 440,000 get it. So I'm way off on my numbers. 440,000 have a binder. 0.5, about 220,000. We'll say 220 was actually 0.45%. Or 45% or 0.45. So we'll say 200,000 stop taking it. Of those, pretty much everyone is not hitting the 4.5 consistently. Sometimes they get there, sometimes they don't. Now that probably is going to impact that number because what they're saying could be a matter of, well, most of them probably miss it, in certain months like November, December, when there's a lot of holidays and food impact. In the summer, certain types of food. But let's say I'll cut this number in half just to be so safe. I'm going to say 100,000 people don't want to take those pills or stop taking those pills. They face mortality for the fact of it, and they're not hitting their numbers when they do take it, and they're certainly not hitting it when they don't. So I'm going to take 100,000 as if the doctors are going to do what they need to do, which is they're going to put them on this drug, which they may adhere to and may actually have a positive impact. What would the number be? I'm not even going to take that number. I'm going to cut that number in half. So I've cut the number in half twice of who will prescribe it, just thinking maybe it's going to take 6 months to get to this. Let's say it's $800 per prescription per month. That's 40 million times 12. That's $500 million. Okay, $500 million. They're going to do 30% in profit. They have 144. Add in 120 million. You get up to around 264. I should have taken 30% of that, but I'm just going to do it at, let's say you get up to 200 million. 200 million divided by 250 million in your available shares. This is the actual revenue. That's 80 cents per share that they're going to get. 22 price to earnings. You get to $17.60. I took 50% of the 80%, then I cut it in half twice. And I took half of that, and then I said, what if we get half of that? So that's 50. That's 50. And you get up to $17 doing it at a 22 price to earnings after taking 30% profit off of the sales at a price point of 800. I don't see when you're at $4 how this is even a decision, because I'm not basing it on they're going to get the whole market. I'm basing it on 50,000. So there was 440,000. Tell how bad I am at math. Yeah, so 11% of the market gets you to a price point of up to 20. So a little under $20 at a 22 price to earnings. That's net earnings. before all the other stuff. Just a very gross, like a very quick number. That's 11% of the market. I think that Exfosa can capture 11% of the market, especially if it has the efficacy. So let's move on. Unmet need. So my saying was unmet need. My numbers are, $17 a share, just based upon the fact that patients are not hitting. They are still carrying a diagnosis of hyperphosphatemia throughout the course of the year, despite 80% of them being on phosphate binders, and an additional 50% of that being on multiple phosphate binders. So that's unmet need. I think mono versus combo is pointless. Anybody who has anything to do with it doesn't matter, because you can prescribe the binder. Okay, so 50% of them are getting a multiple binder. So let's say they prescribe the binder with Exfosa. What difference does it make? Okay, they can not take the binder, because it seems like most of them aren't taking the binder. Half of them aren't taking, not most, half are not taking the binder anyway. So there you go. Outcome doesn't matter. So what I look at is, when I look at Ibsrela and IBS-C, obviously IBS-C is a critical thing. It's not something to smirk at. That is a serious problem that people have. It's not the same thing as hyperphosphatemia. IBS-C is, gas, it's bloated, it's constipation, it's being unable to go to the bathroom. It's a lot of gastrointestinal types of issues. There are a lot of ways that you can work around that. Typically, you're going to be prescribing that to people. I believe, put it like this, in my opinion, the prescription for that are people who have a very severe IBS, because there are other much milder treatments. You can see from the numbers on unmet need that's not the case with hyperphosphatemia, and the outcome of not treating IBS is severe discomfort. The outcome of not treating hyperphosphatemia is people die. They have osteoporosis because it pulls calcium out of the bones. They have a calcification of the I think arteries and things like that. They have lung issues, heart issues, general life. It's just miserable, dementia, and you die, and that's where it goes. So it's not that I'm not saying IBS doesn't matter. I'm saying that hyperphosphatemia is a different thing in terms of the impact. And these are people who are on dialysis. Most of your IBS-C patients are not going to be on dialysis. In fact, there's no connection there. Your hypophosphatemia, they're all on dialysis. So they're already being treated for some kind of it. They're already, chronic kidney disease. So I think that in terms of the projections that I saw from Cantor, when they use those projections, and it looks very similar to what the rollout for Ibsrela was, I just say to myself, well, there's no comparison there. That's a joke projection, in my opinion. Efficacy, does it work? So I think efficacy is the number one point. If you look at all the trials, I'm not going to go through them again. You can look at all my previous videos. It demonstrated success in every endpoint, that pretty much every endpoint that it was given. It works. It works very well. Does it work for everyone? Does it work differently? Of course. Do you pair it with a binder? Do you not pair it? That's for doctors to figure out. The trials are not there to figure out exactly how every single physician is going to use this tool. The trials are there to show that it's safe and that it's effective and it has the necessary efficacy, and it does. Now, let's go to this again. Which is more efficacy? Which has higher efficacy? The pill you will take or the pill you won't? The pill you will take always has higher efficacy than the pill you won't take. Half of them stop taking or aren't taking their phosphate binders. They're just not taking them. It's too many pills. The adherence is long, and they already have enough pills to take, and they don't. It's just a massive pill burden. So if you can get them to take it, all those numbers are going to improve. Even if it does exactly the same efficacy as the other ones, all those numbers are going to improve. So does it have efficacy? Well, if they take it, it does. So, and I think that's the number one point. There's a second point I want to make, and this is just research that I've done, just looking at different studies. So hyperphosphatemia, phosphorus levels, it's not that somebody who's on dialysis, who has chronic kidney disease, is going to sit down, they eat a meal, they don't take the binder, and then immediately they feel terrible. That's not how this works. It's they take the binder, phosphorus builds up in their system, and then there's almost like your circadian rhythms, where throughout the course of the day, the amount of impact changes. It actually hits them. You have phosphorus levels, it builds up, and then the actual phosphorus levels rise at certain times. So usually, I think from the things I saw, it was like four in the morning to 8 in the morning is the highest level of phosphorus. So why do elderly people with CKD wake up early? Well, because all those levels that are no longer being managed by their kidneys and their liver, they start to go up and they jump up, and it wakes them up because their body is actually starting to go into some serious problems. They can't sleep through it. So is the efficacy just a matter of reducing hyperphosphatemia? I think there's that. I think there's also the fact that what it does is it blocks that transport layer so that you're not picking up more phosphorus in your level. It keeps that level down regardless of I think this is what I think. This is just an opinion of mine. It's a guess. I think the doctors are going to go out. They're going to start doing what they do, which is they figure out how to best treat their patients. And they're going to find that a binder, lower that binder so that people will take them, so the patients will take them if necessary. Get them taking this pill, and it's going to create a cycle to where it's a better for them in terms of their entire overall experience of life, because it's going to be. It doesn't require you take it before you eat, but I think that it blocks that transport so that it's making sure that the uptake of phosphorus is leveled throughout that day. And then what that's going to do is it's going to lead to a better impact overall. Meaning, how do I put this? If I, in terms of my adherence, I'm told you have to do this when you eat or you're going to get sick. And then I don't take that pill and I eat and I don't get sick, but I get sick the next day. I don't associate the pill with the sickness. So then I just say I'm sick. Whereas if you take that pill, it blocks the transport layer, you give them the binders and they continuously, so you've reduced the pill burden, you give them the binders and it reduces that impact. They start to associate, you take these pills, you'll feel better. It will be a loop back on adherence to where they continuously take these pills and it helps them. They may drop that binder, but if they drop that binder, you still have something that is blocking the transport layer, the uptake, and it's keeping the phosphorus from accumulating. But this is what doctors figure out, not me. I think giving them this tool, they're going to figure out a way to take care of this hyperphosphatemia, which again, it's an unmet need. Meaning they have a tool that's going to give them some real the ability to really put a dent in this. That's what I believe. That's why I've invested very heavily in it. In addition to I think it's incredibly cheap at this moment. And that's just, these are my thoughts, my opinions. I'm not a healthcare professional. I work around it, but I'm not in it. And I'm just an investor. So that's what I think. In 7 weeks, we're going to know if it gets approved. What do I think will happen to the stock price? Probably going to drop dramatically. We'll be right back where we're at right after approval. And then, 2 quarters is what I'm looking for. Let's see what they do in 2 quarters. If the sales are terrible after 2 quarters, then, I don't know about the rest of you. I bought in, it was under $1. So I'll hold for the next 2 years. I don't really care. But that's all I got to say. I mean, as far as videos, I've been talking about ARDX since the summer of last year. I put out probably half a dozen videos on it. I'm pretty pot committed at this point. I don't really care about price fluctuation. I don't even look at it. I do spend a little bit of time. I just kind of jump into stock twits and write very quickly. But I'm going to hold this. That's my opinion. I think that if you're willing to hold it for 6 to 12 to 24 months, and you're willing to just weather the storm of, there's going to be FUD, there's going to be market makers doing what they do, algorithms doing what they do, and it's going to drop, it's going to go up, it's going to drop, it's going to go up. But I think that this is a great product. I think it's a really great company. The more I look at it, I like their CEO, Rob. I think I don't like him as a person. I don't know him. I like what he's doing. And I definitely, their commercial lead, she is, the results are there. So you can't say whatever you want about any of them. You can't deny the launch of, Ibsrela is just a tremendous launch. And that's what I do in this industry. So knowing what they had in terms of resources and knowing what they've accomplished in terms of those resources and what the market is truly like, they have a commercial lead who is above and beyond. Probably, this is something I know a lot about, quite a lot. I have a lot of experience, over a decade of experience. I tend to work with the commercial folks a lot, and this is as good as it gets for having no resources and having that kind of just consistent, 40 to 60% quarter over quarter growth without, I think they have a 60-person sales force. That's not big. And if you're looking for comparisons, if you're somebody who's really into small cap biotech investing, look at Jazz Pharmaceutical in terms of like how their stock price fluctuated, because I see a lot of early Jazz Pharma in our ARDX in terms of the stock profiles and they got beat down a lot with their CRL, which Jazz didn't have that issue quite so much. But in terms of just, I see some similarities. So anyways, that's it for me. I'm probably not going to do another one of these for ARDX just because I don't know what else there is to say at this point. I mean, I think anything else is really just, it's just a distraction. I mean, maybe it'll get bought out. Maybe the kidney, one thing I didn't cover, the Patient Kidney Act. Originally, when I looked at that, I thought that the Patient Kidney Act, will throw that down here. Originally, when I looked at this, I thought, well, they have to be getting bought out, because it was so clear in the language towards serum phosphorus and everything else. I was wrong on that. So I think the main push behind that is that dialysis centers don't want it bundled. So the Patient Kidney Act is with regards to the Medicare bundling for services. Bundling is, let's say, a dialysis treatment center like DaVita. They provide dialysis to a patient, and they could bill for all the little things that they do, or they could get it bundled and they get paid a set price and they have to provide the services a set price. They don't want it bundled. And the reason they don't want it bundled is because they have no control over whether or not people take their pills, which they're not taking their pills based upon the studies. Half of them aren't taking them, or often not taking them. So they don't want it bundled because they don't want the outcome of hypophosphatemia included in how they're rated with regards to their services, and which has an impact on how much they're going to get paid. So I think the push for that is, I was originally looking at it, I was like, well, there's no way ARDX could get that done. Well, it's true. But DaVita could. So I think, or DaVita and was it for Nenesis? There's only a few, there's like 6 major companies that do this, and 2 of them have everything. They could get that done. So they could get some Congress people to put that forward. I think that's from the industry. The industry wants this to be deferred, and they want hypophosphatemia and serum phosphorus pushed off out of the bundling, which I don't think it matters either way. So if it gets bundled, then a company like DaVita has to come back and say, okay, well, if we're responsible for phosphorus levels, then we're going to not need less binders and less Sigfos, and we're going to need more, because they're going to need more money to follow up, and they're going to need more money or reimbursement, we would call it reimbursement, to make sure that to nail down adherence. They're going to need all that stuff. Whereas if it doesn't get bundled, then it's off their plate, which is what they want. So I don't think the Patient Kidney Act matters. I think it'll get passed. They're going to put it off onto Medicare. It becomes Medicare Part D, and then they're going to go and get reimbursement from another Medicare channel. None of that changes. So here's the thing about the Patient Kidney Act and bundling and all that stuff. None of it changes this. It doesn't change the unmet need. It doesn't change that this is the critical outcome. It doesn't change that this has a great efficacy in terms of both the straightforward efficacy and the adherence-related efficacy. None of that changes. It doesn't change that ARDX has a great CEO, and a great commercial, chief commercial officer, and a great commercial team. It doesn't change any of these things. So I don't think this matters. In fact, the only thing I think that matters is they get the approval, and then as an investor, can I just sit back and wait 18 months for this to work out? Maybe they get bought out, maybe they don't. Eventually, the price has to reflect revenue, and if it sells, the price will go up. So I'm going to leave it at that. Like I said, maybe I'll come back later if this does really well or really poorly, and I'll say either, you know, look at how great this did, or I'll say I'm sorry, but I'm not saying I'm sorry. I'm not telling anyone to invest in anything. I'll say I was wrong. That's what I'll say. But other than that, this is it. There's 30 minutes. Have a good one, guys. Best of luck. Take my Sunday.